see that if you need 100% oxygen to have an acceptable oxygen level in the blood, then you probably have a very serious problem. And that's what the PF ratio helps us determine. So this consensus came up with this, definitions, and this is what guided management and research and collaboration for the up to maybe 15 years henceforth. Until, again, consensus experts reconvened, and a new definition was then defined, and this is the Journal of American Medical Association, JAMA, and they basically updated the definition of acute respiratory distress syndrome, ARDS, in 2012, and we had what was called the Berlin definition. Of note, the category of acute lung injury was discarded, and the severity of the injury to the lung was characterized as either mild, moderate, or severe, depending on the PF ratio. Other considerations were that it had to be an acute injury, so a time limit of at least a week, 7 days, up to a week rather, or 7 days was set as to the onset of symptoms, and you have to have chest X-ray changes, which showed evidence of lung injury and too much fluid in the lung, which were not explained by any other condition, most commonly cardiac failure. Now, with respect to pediatrics, there were some concerns with the Berlin definition. This was mostly describing adult characteristics and physiology. However, pediatric patients were also known to suffer from from acute respiratory distress syndrome, but there are a number of differences. One of the considerations was that actually we don't use in pediatrics arterial blood gas measurement as commonly as in adult critical care. We normally, we have moved forward to mostly using a non-invasive measurement called an oxygen saturation SpO2. So therefore, patients, there might be an underdiagnosing of acute respiratory distress syndrome because the definition, according to the Berlin definition, requires an arterial blood gas measurement. The impact of not diagnosing ARDS in pediatric patients is that they don't benefit from the optimal management and that the patients in the adults cohorts get. They're also not included in studies, and so basically knowledge isn't moved forward into how best to manage them. A second consideration was actually there's a huge amount of variability in the way the ventilator strategy we use in mechanically ventilating children as opposed to adults. And this has an impact on the PF ratio, as we'll come to see in a bit. And then there are differences in risk factors, in etiology, and some differences in the pathophysiology, which were not considered. So this then led to a panel of experts in pediatric intensive care medicine convening, as the adults had done, to basically come up with consensus statements on the definition, management, and future research considerations. So 27 experts from 8 different countries convened over 2 years, and essentially then produced a document which is available in pediatric critical care medicine, which is open source. This is a document you can access by the internet without having, and it's not behind a paywall. And basically, they came out basically with recommendations. This group was called the Pediatric Acute Lung Injury Consensus Conference Group, PALICC. And since this time, they have been the foremost guidance on how to manage pediatric acute respiratory distress syndromes. So their main aims were to actually define this, because they thought there's to be some differences to the adults population, to offer recommendations and hence consensus and avoid too much variability in the management strategies, and to identify research priorities and foster research collaborations. And so here we are, pediatric PARDS definitions. There are 5 categories initially. So first, the age. So patients who in the neonatal period are excluded. Neonatal hyaline membrane disease, problems with prematurity, meconium aspiration syndrome that babies get within the first 24 to 48 hours. Those babies will be excluded from this group of patients. But beyond that, so any patient after the age of any patient beyond the age of 1 month up to 17 years can be included. Again, the timing, it had to be an acute insult and not a chronic injury. So within 7 days, there had to be evidence of lung edema. Edema means too much fluid in one area, which was not explained by giving too much fluid to the patient or by a problem with the pump action of the heart, cardiac failure. Chest imaging had to show that there are some new changes, and this, as opposed to the adult definition, unilaterally you did not need to have bilateral lung changes, and there had to be a problem with your oxygenation. So essentially, and this was what was characterized by the preference for an oxygenation index as opposed to a PF ratio. Now, populations that had previously been excluded from ARDS diagnosis were patients such as congenital cyanotic heart disease and chronic lung disease. Say, for example, a patient on chronic mechanical ventilation. Now, these patients are also felt to be able, one is able to diagnose PARDS in them if they satisfy these 5 criteria. The only difference would be that you'd not be able to characterize whether the PARDS was mild, moderate, or severe. So there's no risk stratification, but they would still be included in that definition, and they would still hopefully then benefit from the appropriate management strategies. Again, of note was that actually a new category of patients who are at risk of PARDS was introduced. As we can see there. And this was really just to heighten the index of suspicion and awareness of clinicians managing these patients. So as we can see, these are patients who don't quite meet the criteria in terms of PF ratio or oxygenation index to satisfy, to get into the PARDS group, but these are patients who are likely to progress to PARDS. And the idea was to have that heightened sense of risk awareness of these patients and to escalate management and therapies appropriately. So we've talked a lot about the PF ratio, and so we're going to talk a little bit more about that. So I think I'd like us all to think what our PF ratio is. So if we say breathing air, a normal person should have an oxygen, arterial oxygen level of 80 to 100 millimeters of mercury. And if an FiO2 refers to the fraction of inspired oxygen in the gas you're breathing, and if it is air, that is 0.21. So if we take 80 divided by 0.21, that gives us roughly something in the region of 380 and above. So as you can see, we would want a high ratio and not a low one. And moving more specifically into why the PF ratio is less preferred in terms of characterizing the severity of disease in PARDS as opposed to adult respiratory distress syndrome, the PF ratio does not account for the amount of ventilation pressure that you're using to ventilate the lungs. The majority of these patients will be receiving some form of respiratory support. And as we can see, if you need more pressure to achieve a PF ratio, say of 200, then you're likely to have much worse disease than somebody who needs maybe half the pressure that the machine is using to achieve that PF ratio. And so this is how we come to this new definitions: oxygenation index and oxygenation saturation index. Now, for some of us, this might be the first time we're hearing of these terms. They do correspond to mild, moderate, and severe of acute respiratory distress syndrome in adults. But for the reasons outlined earlier, these are preferred because there's much more variability in the ventilation strategy in pediatric intensive care medicine than there is in adult intensive care medicine. So mild means that you have an oxygenation index between 4 and 8, moderate between 8 and 16, and severe more than 16. And likewise for oxygenation saturation index, if you have mild PARDS, it's between 5 and 7.5, moderate 7.5 to 12.3, and severe more than 12.3. So how do we calculate this? It's actually quite simple. So you do need essentially this calculation is done in patients who are mechanically ventilated, and you'll take a mean airway pressure, which is basically a reading that you get of the ventilator that you're using, and you multiply that by the fraction of oxygen you're receiving, or the patient is receiving, times 100, and divide that by the arterial oxygen level. Where you don't have an arterial oxygen level, as we said, we don't tend to take as many arterial blood gases as in adult critical care medicine. You simply use the mean airway pressure calculation of mean airway pressure times the inspired fraction oxygen times 100 and divide that by the non-invasive saturation that you're reading. That will give you an oxygenation saturation index. And so just to maybe just sort of tie this all up and sort of bring it home, we'll have one or two examples. This is a 6-year-old boy presents with a 6-day history of cough, fever, and increased work of breathing. So essentially respiratory symptoms suggestive of infection because of the fever. The patient needs to be mechanically ventilated because of increasing low oxygen level in the body and decreasing level of consciousness. A blood gas analysis on oxygen, inspired oxygen of 60%, so FiO2.6, and a mean airway pressure of 18 centimeters of water shows arterial oxygen level of 70 millimeters of mercury. Does he have PARDS? I mean, that's his chest x-ray, and from the chest x-ray we can see actually also has the bilateral infiltrates and the parenchymal disease. There's evidence here of lung edema. So going by what we said the definition of PARDS includes or needs, there are 5 criteria on which we'll look against this case example. One is his age, so he's 6 years and he's not a neonate, so he's not less than 28 days of age, so that he would qualify from that perspective. The timing of the clinical insult is less than 6 days. There is evidence of lung edema on the chest x-ray, and from the history, it doesn't seem that this patient has had any previous, any comorbidities that would lead to chronic lung edema, such as cardiac failure or administration of too much fluid. There are bilateral infiltrates, and when you actually calculate his oxygenation index using the method we elucidated in the previous slides, it is 15.4. This also corresponds to a PF ratio of 116, so between 100 and 200. So this patient actually has moderate PARDS. And again, just a final example. We have a patient with a mean airway pressure of 20 centimeters of water, inspired oxygen fraction of 60%, and has SpO2 of or saturation of 98% and an arterial blood gas or oxygen level of 85 milliliters of mercury. The oxygenation index would be 14, the oxygenation saturation index, so say you don't actually have the arterial blood gas measurement to be 12.24. And this patient also has moderate ARDS. And again, if you were to use the PF ratio, it would be the same thing. And that's the end of definition. So in summary, we have new definitions. Pediatric ARDS, there are some differences to the acute respiratory distress syndrome definitions. There's an at-risk group category, and we prefer to use oxygenation index and oxygenation saturation index to PF ratio. So moving on to the pathophysiology of ARDS and PADS. This is a normal lung parenchyma. It's actually really a work of beauty. The surface area of our lungs, if laid out, flat, would be the equivalent of 2 football pitches. This is where gas exchange happens, and this is a more schematic drawing. So essentially, you have the lung divided into ever smaller units up to the ultimate unit, which is at the alveoli, which is gas filled and surrounded by one layer of membrane, and we'll call this the alveolar epithelium. And then surrounding that is the capillary endothelium, which basically and these two basically form the alveolar capillary membrane barrier. I mean, there's some fluid, a slight fluid in between these areas, but as you can see, this is a very, very thin membrane, and that is why it's very efficient for gas exchange. However, it is prone to injury, and this underlies the injury that you see in PADS. Also, as we move on, I'd like us all to think of what's called the baby lung concept. And this was actually described once when CT scans of patients who had ARDS were taken. And what was actually noticed was that the actual part of the lung that was useful of actually participating in gas exchange were in an adult was equivalent to that of, say, a 6-year-old child. So if we look at the first diagram static, so this is when the patient is supine, most parts of the lung were collapsed and not participating in gas exchange, and only the top bits were being ventilated. Things were slightly better when the patient was stand prone. This is a vertebral, this is a schematic representation of a vertebra. So when the patient was stand prone, more parts of the lung were taking part in gas exchange, but depending on the strategy that one was using, the collapse could progressively increase, such that less and less parts of the lung were participating in gas exchange, and actually these parts of the lung were prone to what we call ventilator-induced lung injury. So we'd say that you've got the alveolar epithelium and you've got the capillary endothelium. Both of those can get damaged separately or sometimes in a combined way. And this then results in the type of lung that we see in ARDS and PADS. So direct damage to the alveolar epithelium can come from infectious causes, damaging the actual alveolar cells. And the most common actually in advanced societies is viral infections. And I think with the current COVID-19 pandemic, we have a good healthy respect for the amount of respiratory compromise that a virus can cause. Irrespective of whether viral etiology was the initial insult, bacterial etiology is usually superimposed. And so essentially most patients end up on broad spectrum antibiotics. Aspiration is another common cause of direct injury. We frequently see, at least in our unit, and I think in many units, a child who's come in who has likely choked being fed or for some other reason, maybe reflux. And this also can cause quite a significant lung injury. And then there's direct trauma to the lung, maybe through surgery, or through some other form of trauma like a road traffic accident. Indirect insult to the capillary endothelium happens from mechanisms happening in the body that affect the lung through the fact that the blood vessels, the capillary, is basically having some insult. And this is generally due to sepsis, generalized sepsis, could be due to burns or transfusion-associated lung injury, TRALI. So we can think of 5 main mechanisms in terms of that affect the pathophysiology. And we'll go through them in turn because I think it'll help us appreciate why we do what we do in managing these patients. So essentially the alveolar cell is damaged, yeah, and it's usually the type 2 alveolar cells. Now their work is to absorb extra fluid, so to keep the alveolus gas filled and not fluid filled. And they also produce this compound called surfactant, which basically reduces the surface tension in the alveolus. So when they're damaged, this doesn't happen, and the lung tends to fill up with fluid and it collapses. Also, when they're not able to do their job well, and if the capillary endothelium is damaged, big molecules enter the alveolus, yeah, that gas-filled little bubble. And these molecules also inactivate the surfactant. And again, this leads to the lung collapsing. So this lung, which should be like a little balloon that has gas in it, is basically full of water, and it just collapses and is unable to do its job. Inflammation is also important, which can be local or systemic. So if a cell is damaged, it tends to release chemical mediators. It's the body's way of signaling that it has a problem. Now, these chemical mediators then attract all sorts of cells that are meant to tackle the problem, but within of themselves can be a problem. So you get a lot more fluid moving into the lung because of these cells need to move in with fluid. You get all these molecules filling up the lung. And essentially the lung is no longer a thin barrier that's full of gas that can perform gas exchange. It's basically just a collapsed bag that is unable to perform its job well. Then the cells which are damaged tend to die, and the debris sits there in the lung. It takes some time for the body to clear it up. And what we've also begun to appreciate more and more is that actually this whole process actually causes a prothrombotic state. So the lung is more prone than in normal physiology to clot. And so the capillaries end up having clotting, and that also blocks off large parts of the lung. So essentially, you end up with a lung, rather than being in a nice, balloon sort of air-filled space, you end up with a lung that is full of fluid, that is stiff, and that has collapsed on itself. And to make matters worse, this is not happening in an even way throughout the lung. It's not a homogeneous disturbance. So some parts of the lung are collapsed, others are hyperinflated, some are more fluid-filled than others. And this leads to the classic hallmark of you have ventilation perfusion mismatch. So areas which are ventilated are not getting blood, maybe because the capillaries that have these alveoli have blocked off or are clotted off. And areas that are getting parts of the lung that are getting a lot of blood have no open alveoli to facilitate that gas exchange. So this is called VQ mismatch, and this leads to this severe oxygenation defect. So as opposed to what we saw earlier, this is what the lung ends up looking like. And as the lung starts to heal, it basically starts to heal in a disordered manner. So this membrane, which was nice and thin before, starts to become fibrotic and thick. And basically, you can see that it will take more time for molecules such as oxygen and carbon dioxide to traverse this membrane as opposed to one here. Now, to make matters worse, that's not the end of the story. Mechanical ventilation itself can cause more injury. And these are the main mechanisms. So we essentially put patients who have this condition on ventilators, and the ventilator forcefully pushes in air or gas, gas basically, which could be, have a different level of oxygen, but pushes in this gas in a forceful manner, and the lung is forcibly opened and closed. This in itself is an unnatural process for the lung. And so depending on how it's done, some lung damage will happen. Barotrauma refers to the fact that if you use very high pressures, the lung suffers from that, and it can actually provoke what's called a burst in the lung, an air leak syndrome, like a pneumothorax or a pneumomediastina. So the lungs, the alveoli, basically, once they've reached a point, that thin membrane can no longer take the pressure, will actually just burst open, and that is what barotrauma is. Volutrauma refers to using excessive volumes to ventilate the lung. In the baby lung that we saw that most of the lung is collapsed. The lung that is actually being used in gas exchange is just the top. So if you use excessive volumes or what we now call excessive volumes, but if you use normal volumes as you would in normal physiology, you are likely to stress that little part of the lung, which is actually working. Atelectrauma refers to shearing forces. The next slide will illustrate that a bit better. And again, this stress to the lung promotes the release of these inflammatory mediators, these chemical agents that basically say, oops, we're having trouble, and they try and call in the help, and it makes the thing worse. Also, oxygen is a very reactive species, and too much oxygen tends to react with all sorts of molecules, proteins, lipids, etc., to create a bit more injury. So this is one of the things that in the last 20 years, we've actually, we've had much better appreciation of, that the way we manage the ventilator strategy is very important in minimizing the lung injury of these patients. This is atelectrauma. So basically, the shearing forces, repeated opening and collapse of alveoli leads to some become over-distended, and this stress also promotes barotrauma. And that's the pathophysiology, really, of the lung injury. So with that, we then need to move on to how do we manage this damaged lung in a way that we don't create more problems. As people will say, the cure should not be worse than the disease. So generally, in pediatric acute respiratory distress syndrome, high quality evidence base is low. So prospective randomized controlled studies are not very much available. And therefore, we mainly borrow from the adult data. And where there's no adult data, expert opinion is used. This has resulted in considerable variability in how it's managed across centers, but this is improving following the consensus statements and ongoing work through the pediatric critical care collaborations. So the goals are threefold. We want to treat the underlying cause. As we said, they're indirect or direct causes that have resulted in this lung injury. We want to ensure that adequate gas exchange is happening. The work of the lung is to give oxygen to the blood, which is carried around the body, and all the organs of the body need oxygen. Your brain needs oxygen, the heart needs oxygen to beat, etc. So oxygenation is important, and we need to remove some carbon dioxide, though that is less of an issue than providing an adequate amount of oxygen to the rest of the body, because failure of that means that the patient ends up in multi-organ failure. And then we want to protect the lungs from this ventilator-induced lung injury that we saw can happen. So essentially, the mainstay is intensive care support with particular attention to the ventilator strategy. So we use what's called a lung protective ventilation, which includes allowing the carbon dioxide to be higher than would be allowed in normal physiology, and allowing a relative low amount of oxygen as long as the tissues are not showing signs of too little oxygen. So as long as they're not showing, the patient is not showing signs of going into hypoxic organ failure, so organ failure due to lack of oxygen to that tissue, you can allow a slightly less normal amount of oxygen level in the blood. And these principles mostly come from this landmark trial that compared using large tidal volumes to lower tidal volumes in adults. This trial actually had to be stopped early because interim analysis showed that there was a large mortality difference, a significant clinical and statistically significant mortality difference, and therefore it was no longer ethical to continue with the arm that was showing inferior results. And so the standard of care now became that you ventilate with these sorts of lower tidal volumes. And this really is the only, this is really the main high quality evidence base for the management of pediatric ARDS that we have to date. And again, this is just a slide. I think for those who are very familiar with critical care, they're quite familiar with this slide. This paper was published in the New England Journal of Medicine in 2000, and it eventually showed that there was a survival benefit and a higher likelihood of being discharged home and breathing without assistance in patients who are ventilated using lower tidal volumes. This is just to illustrate some of the tubes we use, and this is a cuffed endotracheal tube, a pediatric cuffed tube, a size 4.5. And I'm just I brought this here really to emphasize that this is one of the main changes that has come into place in the last few years in the management of PARDS. This is a closed suction system, and we'll come to that in a little bit. So essentially, it's recommended that you use a cuffed endotracheal tube. Now, traditionally, pediatric patients have not been ventilated with cuffed tubes, and I won't go into the ins and outs of that at the moment for time, but there's been quite a lot of experience now, and cuffed tubes essentially mean that you have a better seal, and you can use lower pressures to ventilate the lung, and they're much less likely to dislodge. So where you can put a cuffed endotracheal tube, and now they go down to size 3.5 millimeter diameter. Tidal volumes, you use a low tidal volume strategy, as you said, and where you have severe PARDS, even lower. We maintain arterial pH 7.2, greater than 7.2. This normal is 7.35 to 7.45. So we don't try and achieve normality. More than 7.2 is okay. And you can actually liberalize this to 7.15 in severe disease. Obviously, there are some patients where this is not safe. And for example, patients where you need a tight titration of carbon dioxide, like raised intracranial pressure, or patients, say, with severe pulmonary arterial hypertension. But so you titrate your respiratory rate to achieve this pH. Oxygenation goals, as you've said, you need an oxygenation level of 92 to 97%. Titrate your inspired oxygen fraction to that. And you can accept even lower as long as you're not seeing evidence of organ dysfunction. Most organs have some reserve and can do the slightly less than normal amount of oxygen. So this can be acceptable in someone, especially if they were previously healthy. And then we also use an open lung strategy using what we call PEEP. And I'll just explain what this means. So one of the things that the landmark trial also showed that there's no difference with using a high PEEP, so a positive end expiratory pressure. That's the pressure left at in the lung at the end of expiration. There's no difference between this and low PEEP, as long as the peak pressure, and actually technically the plateau pressure, was maintained below a certain level, which was 28. And if you want to look at PEEP this and recruitment, this is a very critical slide. So this is so lung compliance refers to the change in volume for change in pressure. So you have pressure here, and then volume on this axis, and this is inspiration, and this is expiration. Yeah, and the easiest way to explain this is when you use the analogy of trying to blow up a balloon. So if you have a balloon that is collapsed and you're trying to blow it up, at the beginning, you're going to need quite a lot of pressure or force to get the balloon open. Eventually, you reach a sweet spot where where even a little blow can vastly increase the size of that balloon. And then you get to the maximum of the maximum of the distension of the balloon, where increased pressure may simply burst the balloon. Yeah, and there's not much change in volume for that. So that's what's called compliance. So we want to ventilate patients really on what we call the compliant part of the lung curve. So we want to ventilate patients at that sweet spot where you just need a little bit of pressure to get the lung to change in volume quite a bit. And that is what we talk about titrating PEEP. And so you can increase the PEEP slowly, looking at your oxygenation, your compliance. That the compliance is another measurement that you get off the ventilator, until a point where you don't get any improvement with increase of PEEP, and then you can then decide that PEEP and 2 centimeters above or below is the best. Pragmatically, in pediatric patients, we start off using these tables that compare, that recommend the types of level of PEEP you should use for a certain amount of inspired oxygen fraction. So we start off with that, and another very good strategy for recruitment is proning. But essentially, we then move, you basically, with the recruitment maneuver, you get to where you're at the top of the inflection point, and then you want to come back down to where you're still at the very compliant part of the lung curve. Just to summarize, sustained inflation maneuvers, so, giving a huge, big positive pressure breath is not recommended because of these reasons, that you can basically end up with an air leak syndrome such as pneumothorax, and also that you can impair venous return and end up with a cardiovascular crisis. And now, to just as you're winding up, additional ventilator strategies in addition to that lung protective ventilation strategy that will help with managing these patients. So it's recommended that some patients who are likely to struggle to come off mechanical ventilation, such as immunocompromised patients, have their therapy escalated as quickly to avoid needing as much mechanical ventilation. And so a non-invasive positive pressure ventilation strategy, such as using a certain type of tight-fitting face mask that can help, that can be attached to a ventilator and help with breathing, is advocated. So that's recommended. There's an advanced level of ventilation called high-frequency oscillatory ventilation. And this is basically more or less a rescue therapy, where conventional mechanical ventilation has not achieved the goals that we wanted, i.e. adequate oxygenation and some removal of carbon dioxide. Note that there's a trial looking at this. This is something that we have used also in Gertrude's with some good results, although we don't have as large numbers, because with the other strategies we do manage to manage enough of these patients well enough with conventional mechanical ventilation. But this is an additional step that you can take, and it's really when you have optimized the normal ventilation strategies. If the patient is having asynchrony, so not the patient is possibly coughing or fighting the ventilator, and sedation alone is unable to achieve adequate mechanical ventilation, then judicious use of a paralysis, neuromuscular blockade, is advocated. And where available, you can do life support on pediatric critical care, and that's called extracorporeal membrane oxygenation, and similar to what patients have when they're having open heart bypass surgery. Other strategies that that need to be considered in specific populations, at which the consensus group could not recommend for every patient, are as follows. One is turning the patient onto their front, what's called prone positioning. For those who have been paying close attention to what's been happening with COVID-19, I think you may have seen this term used quite a bit. Luckily, it's very easy to prone a child as opposed to an adult, you know, turn them over. And as we've seen, once you do that, more part of the lung, so the lung bases which are collapsed and tend to be recruited into gas exchange, and you don't have the weight of the heart and other mediastinal you know, organs pressing down on the lung. Yeah. Surfactant, which has been very helpful in newborns who have newborn respiratory distress syndrome, usually due to prematurity. It's not been as useful in pediatrics, so outside the, you know, that age group. But it has been used, and sometimes it works, sometimes it doesn't work. Therapy like inhaled nitric oxide is not something that's available here, but it is available in other centers outside Kenya, and it's used in specific populations, essentially for patients who have you know, very severe right ventricular dysfunction, severe pulmonary arterial hypertension, and as a bridge to the life support that we talked about. Steroids, again, you can be used, they don't require to be used routinely for everybody, and even the timing also depends on the actual goal you want to achieve, whether you want to have a smooth extubation or you have a patient who needs a much higher dose of steroid and is in the proliferative fibrotic state of ARDS. So there's no contraindication to using them, but it cannot be said that they should routinely be used from the beginning for all these patients. And this is just to say that as we have seen, that there's only one area that has what we call this high quality scientific evidence. And this is now a new trial that's been recruiting patients, and hopefully this will better guide these particular aspects, particularly proning and using the high frequency ventilation. Of note, proning has a survival benefit in adult patients with severe ARDS. So it is becoming actually even a standard of care in those patients. And then finally, a number of another considerations. So it's really important to have a goal-directed fluid management therapy. So it's acceptable to, in the first 48 hours, when you have signs of, you know, shock, to administer a lot of fluid. But after that, a more conservative approach results in less ventilator days and reduced length of stay in hospital. Essentially, a cumulative fluid balance of more than 10% is associated with worse outcomes. All patients there should be attempt to feed enterally patients within 24 hours of mechanical ventilation and sedation. So an NG tube should be sited. It will help with compliance, and you can at least begin to administer some nutrition, even if it is not the full requirements that they would need. Sepsis and this situation, sepsis and PARDS is a catabolic state, so there's a huge energy requirement that the body has. And keeping patients fasted, as we used to do for 5 days up to a week, is no longer acceptable. And transfusion. So in patients who are previously well and who have no cardiac disease or are not actively bleeding, a transfusion trigger of 7 is permissible. So attempting to transfuse everybody who is less than 10 is no longer, is not shown to have any benefit. Of course, there are those populations, as we said, cardiac disease patients who are actively bleeding, where you can use a higher transfusion figure. but actually anemia is well tolerated. And there are problems and side effects of transfusion that have resulted in the guidance and management changing. And this is, I think for those who deal with adult critical care, this is something that's quite well known. So in summary, PARDS has a significant mortality and morbidity, even for the patients who survive. Some of them survive with a lung capacity that's maybe 60 to 70% of what it was before, making them more prone to further lung compromise and reducing their reserve in terms of dealing with any future insults. The mainstay of critical care management is this lung protective mechanical ventilation strategy. Don't be afraid to use a endotracheal tube and to prone the patient. As I said, it's very easy to turn a child over as opposed to an adult. And obviously we can't afford to forget all the other aspects of organ support, such as the goal-directed fluid management, the goal-directed sedation management that support the body and help to achieve the best outcomes. And I think that's what I have to say on pediatric ARDS. I have a few slides on COVID, pediatric COVID. I'm hoping Idris and Chikophe and Dr. Isaac Adembesa can chip in on this. Angela?
Yes, Dr. Manguyu. So you can go ahead. We have some of them online, and then probably we'll do another session and come back to it. So you can go ahead. Thanks a lot.
I think if I carry on, it might be easier to then wrap up, and then we can have obviously Ms Pharma.
Okay, good.
Speak. Yeah,
okay.
Right. Okay. So, so pediatric COVID, as I mentioned earlier, there was this anticipation because COVID causes essentially ARDS and has been wreaking havoc globally, that we would all be needing to be supporting a lot of these patients on ventilators, which is, as I said, is quite common for ARDS and pediatric ARDS, which is what pediatric patients with COVID will be presenting with. However, it seems to be a much milder illness in children than in adults. So in China, there was evidence that actually children were much less affected. Very few of them ended up in intensive care, and the mortality was actually very, very low. Now, recently, obviously this is a fast-moving situation. JAMA have published this article that basically characterizes the patients who ended up in pediatric critical care units in North America and Canada. Interestingly, Canada had none. And in North America, they had about 48 patients, all across 46 ICUs. And essentially what I would say, not to take up too much more time, is that it seems the typical COVID-19 infection in children seems to be much less severe than in adults. Of the patients who in that group who were admitted to ICU, most of them had comorbidities, significant comorbidities, including cardiac disease, immunocompromised, sickle cell disease. Some are patients who are already on ventilation. And basically worsened. So up to 83%, that's 4 out of 5, had some other pre-existing comorbidity. 38% of them ended up being ventilated. And actually, of all the patients who were admitted, the mortality rate was less than 5%. So this is quite low when you compare to the adult population. However, that's not the end of it. And now there's a new syndrome that has been associated with COVID due to a disordered and exaggerated immune response. And this syndrome is similar, but not quite the same as other type of what we call hyper-inflammatory syndromes, such as Kawasaki disease and a number of others. And basically this presents with a very high fever and multi-organ involvement. So the lungs are affected, but most critically, the heart is affected. The heart is not able to perform its pump action well, and so the blood pressure drops, and sometimes the heart vessels are affected chronically. The blood vessels of the heart are damaged chronically, and so this is a very serious condition that can lead to lifelong sequelae. We're still getting to know more about this. Alerts are put out about it, and we hope that we don't see many of these patients. Of note, there are some genetic differences or variances, and in UK data, many of the patients who had this multi-system inflammatory syndrome were actually of Afro-Caribbean and Asian origin. And so that is something that we here will be looking out for quite a lot. It tends to happen much after the initial sort of infectivity, which may be symptomatic, has happened. So that is this. In Gertrude, we've tested about 50 patients for COVID, and none of them so far have been positive, thankfully. And so I don't have much more personal experience that I can offer. So I think at this stage, I'd like to end there and maybe hand over to any my colleagues who have been working in COVID centers, and they might have more to add to that.
Thank you, Dr. Manguyu. Thank you very, very much for a wonderfully informative and relevant presentation. I'll ask you to just hang online as we allow our sponsors who've been so generous in supporting this webinar. This is MS Pharma, and the presenter will be Dr. Ahmed Larif, Group Product Manager, Sub-Saharan Africa. Dr. Larif, welcome.
Hi everyone. Thank you.
Thank you.
Hi everyone. This is Ahmed Larif, Group Product Manager for MS Pharma. First of all, I would like to thank Kenya Society of Anesthesiologists and Critical Care Society of Kenya for hosting us today. Thank you, Dr. Manguyu. Thank you very much for your lecture. It was very informative lecture. Thank you very much. Hope that everyone has enjoyed it as I did. I will start with a short introduction about our company. So our vision as MS Pharma is to be the leading pharmaceutical and healthcare provider and the partner of choice in META and pharma emerging markets. Our mission is to improve our community's quality of life by increasing access to high quality and affordable products. And our core values: integrity and transparency, quality and excellence, teamwork, respect for people. This is a brief history about our company. MS Pharma now today is a leading company in the META region, Middle East, Turkey, and Africa, and plans to grow in another emerging market also. Our history starts back in 1989 with the establishment of the first company and the first plant in the region to receive the first European GMP certificate. In 2009, we established Al-Kindi, one of the largest pharmaceutical company today in Algeria. In 2011, we acquired unique injectable plants in Jordan. So 2013, it was the year of the integration of all our affiliates under the umbrella of MS Pharma. So it was the year of launch of the corporate head office. In 2016, we acquired a plant, also state-of-the-art manufacturing plant in Turkey, 2018 in Saudi Arabia, and recently in 2019, we acquired Gene Pharma, one of the largest pharmaceutical company in Greece. Revenue end of 2019 is about $270 million, over the increase is 23% over the 8 years. We have almost 700 employees, have 727 registered products in all our region. And we have 341 pipeline products. So we are one of the fastest growing company in the META region today, in the chronic disease therapeutic area. So our product as United Pharmaceutical and Ms Pharma injectables under the umbrella of Ms Pharma are available through our agent and distributor in Kenya, which is Generics Africa. Now we will go through our anesthesia trolley, our product portfolio, anesthesia portfolio product in Kenya. First is the Bitolina as bupivacaine. So Bitolina is a potent agent capable of producing pronounced anesthesia. Bitolina is a popular drug for providing pronounced analgesia during labor or post-operative period due to first long duration of action or tendency to provide more sensory than motor block. Bitolina significantly extended the period of pain relief. Anesthetic effect lasted 4 times longer than those of lidocaine. Bitolina can be used for a number of anesthetic techniques, including local infiltration, minor or major nerve blocks, and epidural block. Bitolina, it's 100 milligram per 20 ml solution. For each 1 ml contains bupivacaine 5 milligram in pack of vial of 20 milliliters. Second product in our anesthesia trolley is Sidalam as midazolam. Sidalam has a rapid onset of clinical effect and short duration of action. Sidalam with low toxicity confer a wide therapeutic safety margin. Sidalam has a number of advantages, including significant anterobroid amnesia, a minimal hemodynamic effect and sedation dose, mild respiratory depression, and relief of anxiety. Sidalam pre-medication is an effective way to reduce the frequency of post-operative nausea and perhaps vomiting and increase patient satisfaction overall. So Sidalam is indicated for conscious sedation, pre-medication before induction of anesthesia, induction of anesthesia, sedative component in combined anesthesia, and sedation in intensive care units. It's available under a form of 5 milligram per 5 ml. So each one contains 1 milligram in vial of 5 ml. And we have also, beside that, Sidalam 15 milligrams per 3 ml. Each 1 ml contain 5 milligram in pack of 3 ml vial. Our third product is amicine as amikacin. Amicin is the broadest spectrum aminoglycoside.
All right, thank you. Bye.
Gram-negative bacillary infection in hospital. Amicin is very effective against Enterobacter, Klebsiella, and E. coli. Amicin as amikacin is effective in pediatric infections and is well tolerated by children. Amicin is used in the treatment of gram-negative infections in the following: bacteremia, pneumonia, osteomyelitis, arthritis, meningitis, skin and soft tissue infection, and intra-abdominal infection, in burns and post-operative infection. So it supplies in pack of containing 500 milligram per 2 ml in a pack of 5 vials. So we have large trolley of anesthesia product coming soon under registration to our actual anesthesia trolley is this following product. We have coming soon cisatrachlorium, atrachlorium, rocuronium, we have tramadol, and ondansetron, and also we have lidocaine is under registration. Thank you all. Thank you very much. Thank you for your attention. It was a real pleasure to meet you today. And we as Ms Pharma, we are looking forward for further collaboration. Thank you, everyone.
Thank you, Dr. Larif. Thank you very much for your time, and thank you so much for your support. Thank you for investing in this webinar, and we look forward to working hand in hand with you. Thank you. So now I'll invite Dr. Isaac Adembesa to log on. He's a consultant cardiothoracic anesthesiologist based at the Kenyatta University Teaching, Referral and Research Hospital, and I will declare him as our national COVID expert. So he'll just share maybe a few comments, if you can, Isaac, on your experience with pediatrics and what you're seeing. Isaac will take the floor, and Dr. Manguyu will also stay online. We also wanted Dr. Chikophe to join us. He's currently indisposed, but we'll carry on if he's able to hear. Dr. Adembesa. So as we try and get a hold of, okay.
Hello?
Hi, Dr. Adembesa. Daktari. Sorry, so I'll give him some time to log on and off, and I won't preempt his comments. Dr. Manguyu, all I can contribute, maybe I'm going to say maybe we can take, since our time is running. Okay, Dr. Adembesa, you're on.
Can you hear me?
We can hear you.
Okay. Thank you for giving me this opportunity. Sorry, I don't have any slides. From KU Hospital, our experience with pediatrics, we've had about 20 pediatrics, but lucky enough, majority of them have been asymptomatic, and I think one or two just had mild disease. I work in ICU, so we've not had any pediatric admitted into ICU. But I guess hopefully we won't get any, child or any pediatric being admitted to ICU. Yeah, but the principle, I guess, will be the same. From our experience with the adults is, if you can delay intubating these patients, then it's better for the patient. We've seen that the patients who get intubated and are ventilated, they tend to do poorly than those who are not ventilated. So based on that, we've adopted a policy where we try to give these patients high flow oxygen and encourage them to prone themselves if they're conscious as much as possible. And we've seen fantastic results with that. For the ones that we've had to intubate, and we really have a strict intubation criteria where unless a patient is hypoxic on high flow oxygen, and when I talk about high flow oxygen, we don't have the nasal cannula, so we just use the normal non-rebreather mask. We've, from our experience, learned that if you've protected yourself well, there is no need to worry about aerosolization. We again adopting non-invasive ventilation as much as possible. We've tried that in a COPD patient and he did well. So for those who are intubated, our average time on the ventilator has been about 10 days. So it's really something that once you commit yourself to intubating a patient just know they're going to be on that ventilator for long, and their chance of dying is even higher. Our biggest challenge has been fluids. You know, how much fluids you give to this patient, because on one hand, if you are very judicious with your fluid, you tend to worsen your oxygenation. But on the other hand, if you limit their fluid, again, they tend to go into renal failure. So we are lucky in our unit, we have ultrasound. So we are using more and more of ultrasound to guide us in terms of fluid status for these patients. So we keep checking their IVC, we keep doing lung ultrasounds just to check where we are. And then, as I mentioned, we encourage early proning, both for awake patients and intubated patients. And then with the new evidence that is coming out with steroids, initially we only used to give steroids to, you know, the critically ill COVID who are having a cytokine storm. We used to give them steroids, but now we've changed our policy based on the new evidence from the UK. So we are going to give all our patients with severe disease dexamethasone. And then, of course, if they're admitted in ICU, again, these are not your usual patients where you'll have the nurse around the bed 24/7. So you really have to have a good sedation strategy. So in terms of reconstitution, your infusion drugs for sedation, you might consider, you know, higher concentrations so that your infusions can run for longer hours, just to avoid the patients breaking sedation and then ending up extubating themselves. For us, it's standard on admission. We put a central line because you don't want a situation where, you know, your line is tissued and then the patient has to, you know, they break from their sedation and they extubate themselves. So when we admit a patient to ICU, we put a central line, and we even go ahead put an arterial line. We put an NG tube for enteral feeds. That has become our standard. And then in terms of who are the patients who mainly end up in ICU, again, so far from my experience, all these patients have comorbidities. Top on the list is diabetes. We've actually had 3 patients coming in DKA. So that is, be very careful when you see those DKAs coming to A&E. Just try and make sure that it's not COVID, yeah. And then HIV, again, like right now, I think about 3 or 4 patients in our ICU, HIV positive. Patients with cardiac disease, they don't do well. 2 of our patients who had cardiac disease, they died. And then we've also had patients with TB and coming with COVID. We've had a patient who had cancer, COVID, again, passed on, yeah. So maybe learning from our experience from adults, I would say we are lucky, and I hope it stays that way, that majority of the children who get the disease are actually asymptomatic. And those who happen to have symptoms, then they only have mild disease. We hope it remains that way. But in the event that, hello?
We can hear
Hello?
you.
We can still hear you, Isaac. We can still hear you.
You can hear me? Yes, yes, yes.
We can hear you,
so, okay. So I was saying, what we've learned that majority of the patients who, for pediatrics, they are asymptomatic actually. And those who have symptoms, they just end up with mild disease. Yeah. So what I can, and then the other thing is learning from adults. Let's try as much as possible to avoid intubating this patient, unless a patient is hypoxic, on high flow oxygen, and their work of breathing, you know, is compromised. They're getting tired. Then those are the patients you should consider intubating. Yeah, because once you intubate them, they stay longer, and it's a challenge getting them off the ventilator. Yeah, that's my message for today.
Thank you, Isaac. Thank you so much for your contribution. Just as maybe an addition, we have cohorts out there, members of our fraternity or larger medical fraternity. I've been speaking with one, Catherine Oyeke. She's a pediatrician and a neurology fellow in Cape Town, South Africa. So their stats, just very briefly before we go to a Q&A session, are sort of Dr. Manguyu were asking, they sort of have had in the last month maybe 9 or 10 patients. And again, their population is pretty similar to us. So the comorbids, everyone seems to have most of them seem to have an underlying protein energy malnutrition, but certainly every other comorbid, including just leukemia and any oncology, even severe trauma, patients who are immunosuppressed, maybe from steroids for various autoimmune illnesses and inflammatory conditions. But they seem to, what they are seeing is, I mean, when we talk about genetic variants, it's difficult to say because the catchment is really lower middle to lower class. So then you have a very heavy sort of Afro-Caribbean Black presence in the critical care unit in general, but certainly they haven't had any Caucasian children intubated. So they only admit high care sort of patients. But the course is when they're intubated, it's a very short course, either to discharge or to death. And that ranges between 3 days and 7 days. So again, those numbers are small numbers. They may not be representative of different populations, but something to think about. Dr. Manguyu, let me just let you get the questions in and let's move along. We have, I think, 10 minutes. Someone, Abuya, was asking, what level
Angela?
Hello. Dr. Manguyu, you can hear me? This is Dr. Nabulinda. We seem to have lost Dr. Angela.
Hello. My apologies. I'm having some technical difficulties. Can you hear me?
Yes, we can hear you.
Okay, I'm sorry about that. Sorry. Dr. Manguyu, the question about what levels of high PEEP are recommended for children, Abuya was asking. Hello?
Yes, we can hear you.
Okay, yeah, thank you for that question. I was anticipating it, and I was actually discussing it with my colleague, Dr. Chikophe. There are two quick ways to answer this question. Firstly, there are PEEP and what's called FiO2 tables. So, for example, if you need an FiO2 of 80% to achieve an oxygen saturation above 92, there's a recommended PEEP that you should use. And there are two sets, one for the high, one for the more severe ARDS or PARDS, and one for the mild one. So you can basically decide which PEEP to use just from that. Or you can basically use a moderate level of PEEP, 8 to 10, in a patient who has a higher FiO2 than 60%, and then perform a recruitment maneuver, of which the easiest to do in a child is proning. The incremental PEEP titration requires that you do serial blood gas analysis. It takes about 40 minutes to do, and in pediatrics has led to a number of problems, including hypotension, and if not done well, can basically, people have ended up using much higher levels of PEEP than they need, because once you reach the top of the inflection point of that lung inflation curve, you need to come down to just to the point where you are beyond which you de-recruit. And basically at that point, when you start to de-recruit, which is about midway down that curve, then you got 2 centimeters above. Technically, it's difficult to do because when it has been described in literature, there have been measurements of PaO2, arterial blood gas oxygen, and as we said in pediatrics, that's not something we do very frequently. So as a ballpark measure, start with a sensible PEEP of between 8 and 12, of which you can use those PEEP tables. Unfortunately, I didn't have a diagram of one. And then if you continue to measure your variables and then prone the patient, which you should do for at least 16 hours initially in 24 hours.
Thank you. That's a very clear answer. Thank you. Let me just go on to the next one. We have 6 minutes. Question is from Samuel Duarte. With such low tidal volumes of around 3 mils per kg, how do we sort of cater for the proportionately larger dead space fraction in children, especially if doing fairly infrequent BGAs?
That's a very good question, and thank you for that. In practice, this, as we said, we don't have any robust evidence in pediatrics for this low tidal volume strategy, i.e. a prospective randomized control trial. So we've simply used what the adults have been doing. And because that particular trial and strategy had such a significant effect, it will not be possible to perform this trial. But prior to the ARDSNet trial, there are a number of observational studies that showed actually the pediatric patients being ventilated with slightly higher volumes than the 3 to 8 mils per kg were not doing badly. However, if you do that, however, that's not what we're advocating now. That ship has sailed. As we said, we're not going to be able to get a prospective randomized control trials now study on what tidal volume to use. We're going to use the one that we've been using from ARDSNet. So essentially, use first two things. Number one, do as much as possible to reduce the amount of dead space you have. That's from the bacterial filters that you have and shortening the ET tube. Secondly, use most modern ventilators, which can ventilate pediatric patients, have some compensation for dead space. And so the ventilator should be able to assist you. In practice, we very rarely need to use as low as 3 mils per kilogram. So I can tell you from the many patients that we ventilated, most of the time we don't need to go down that low to achieve those goals that we outlined earlier.
Thank you. Let me hit you with maybe 2 more. Let me put them together. One is about proning, and in terms of duration and frequency, what would be a proning strategy if there is one that you would ascribe to? And then another question is, how often do you do chest X-rays in these patients, considering it's one investigation that shows typical changes in ARDS?
Yeah. Okay, so proning an assessment of the severity of PARDS within 6 hours of beginning therapy is an indicator of mortality and outcome. So if after 6 hours of optimizing your ventilation and having the patient on the ventilator and doing if it is fluid resuscitation that is required, etc., you do not have adequate gas exchange in terms of the goals we set, we need to have an adequate SpO2, you need to have an adequate pH. And if the signs of organ dysfunction are beginning to set in, then you should prone the patient. As we said, it's also a recruitment maneuver. So proning the patient should be done for 16 out of 24 hours in one day for the benefit to be realized. Now, if you only want to use it as a recruitment maneuver, not as an ongoing strategy, you can deprone the patient after that, and usually the patient has moved to moderate to mild category of pediatric ARDS. However, if they remain in a severe category, then you need to carry on with the proning for at least 16 hours in every 24 hours until you get improvement or until some other problem comes up. That will be a contraindication to proning.
Chest X-rays?
Now, chest X-ray, obviously you need the initial chest X-ray. Once you have the chest X-ray, the rest of the monitoring, the vital signs by the bedside, so the SpO2, the carbon expired carbon dioxide, and then the ventilator measurements, and a blood gas analysis should guide you. And you don't expect many chest X-ray changes within, significant within 48 hours. So essentially, it's only when you get a situation such as a dramatic change, say for example, in lung compliance or in some other parameter like a dramatic desaturation, that after troubleshooting you cannot get to the bottom of that, you repeat the chest X-ray. So a chest X-ray in the first 48 hours is okay. After about 72 hours, it's good to see what the progression of the lung disease is, if it's resolving, if it's static or it's worse. And thereafter, every 48 to 72 hours or even longer, depending on the clinical progress.
Thank you. That's very, very clear. Thank you. Just because we are pressed for time, I'm going to wind up our session. Dr. Manguyu, thank you so much for an excellent, excellent presentation. You really filled our armamentarium with lots of pearls. Thank you for a wonderful presentation. We thank you, Dr. Adembesa, for your contribution. Thank you for keeping us abreast with everything that's going on. You have your finger on the pulse with all that's going on, and we thank you for always being available. We've been counting on you time and time again, and you always answer our call. And to Ms Pharma, Dr. Larif, thank you for supporting us. We are looking forward to more of these engagements. For the audience at large, thank you for tuning in. Thank you for your questions. I know there's some questions that we probably haven't addressed. I probably haven't gone into them. We will provide Tari's email address, if that is okay with you, and you can contact her directly. And if you have any comments, suggestions, any topics of preference, we ask that you email us through the administration's contacts. Thank you very much, everyone, and have a good night ahead.